Hi, my name is Chris Nevala. I'm a GI medical oncologist at the University of Utah Huntsman Cancer Institute. So I had the pleasure today to talk about some of the updates in the non-colorectal GI cancer space. While these abstracts in the non-colorectal space didn't get quite as much press as the colorectal cancer updates did, I still think there were quite a few interesting things that we learned from ASCO this year. In the field of pancreas cancer, we had a really interesting study from the sequence trial showing that if you sequence gem-nab-paclitaxel followed by FOLFOX, you can improve overall survival and objective response rates in patients with advanced disease. I think there's still some questions left to be sorted out on whether or not this will change the standard of care compared to FOLFIRINOX, which we typically use for most of our patients in the clinic right now, but some exciting ways that we might be able to use cytotoxic therapies better for patients with pancreas cancer. What the sequence study still showed us, though, is that our patients with pancreas cancer still have dismally poor outcomes, and we need to find novel treatment strategies and new ways to take care of these patients in the clinic. So another study, the Notable Trial, looked at the addition of an anti-EGFR monoclonal antibody to gemcitabine. This study was a positive study. It showed an improvement in overall survival by targeting anti-EGFR, specifically in a KRAS wild-type population of pancreas cancer patients. I think the results of this study are intriguing. I don't think they quite yet change the standard of care. I think we need to combine an anti-EGFR monoclonal antibody with more standard cytotoxic therapy backbones like gemabraxane or FOLFIRINOX before we can move into the clinic, but I think it highlights the fact that there are unique subtypes of pancreas cancer with different underlying biology for whom different therapies might work better. One of the more interesting areas in the non-colorectal GI cancer space this year, I think, was biliary tract cancers. So we've had all sorts of new studies published in this space over the last year or so, and I think it's becoming increasingly clear that for our patients with advanced disease, sequencing is extremely important, and targeted therapies have the potential to change outcomes for a large number of patients. One of the specific studies that we saw in the biliary tract cancer space was the HERB trial, which looked at the use of trastuzumab deruxtecan in patients with HER2-positive biliary tract cancer who'd previously received therapy. We saw relatively impressive objective response rates for these patients. What was intriguing in this study is that we also saw, while not a high response rate, not a 0% response rate in patients with HER2 low expressing tumors. There's a lot of work that still needs to be done, but I think this is opening the door to broadening the number of patients who might be benefiting from HER2 targeted therapy. It's important to note with that study that there were some significant adverse events, specifically pneumonitis and ILD, and we're going to have to sort those out as we move on to larger trials. And then one other study in the biliary tract cancer space that I think was really important was the updated results of the Phoenix CCA2 trial. This trial showed that with futibatinib, you can achieve very impressive objective response rates, over 40%, and median overall survival of 20 months in patients whose tumors harbor an FGFR2 fusion or rearrangement. We've got a couple FGFR inhibitors in this space now, and this is clearly a space where we need to be sequencing our patients and looking for these alterations because they can improve outcomes. And then the last study I discussed today was the Dante Trial, which looked at can we improve outcomes by adding immunotherapy to perioperative FLOT for patients with resectable gastroesophageal cancer. The study showed that pathologic outcomes were improved, but I think we really need to wait for long-term results of DFS and PFS before we make any changes to our practice there. So I think the summary of my findings, or the findings at ASCO this year, are that we're making improvements. Targeted therapy and personalized medicine have a chance to change outcomes for our non-colorectal GI cancer patients, and so the future looks bright. While I don't think any of the studies presented at ASCO this year in the non-colorectal GI cancer space directly impact how we're going to take care of patients today, I think the most exciting space would be the Phoenix CCA2 trial, where we saw these really impressive objective response rates and an impressive median overall survival with the use of futibatinib in patients with biliary tract cancer whose tumors harbor an FGFR2 fusion or rearrangement. If this drug is improved, it's going to be added to the list of other FGFR inhibitors we have in this space, and I think is certainly going to help improve outcomes for our patients.